What's up, everybody? It is the PA Professor back with another video today. And today we're going to cover all three heart blocks, or also known as AV blocks. So let's just go ahead and get started. So a heart block, or an AV block, is just when the conduction of the heart is slowed or stopped going through the AV node. That's why it's also called an AV node block. So we know down here in normal physiology is that the SA node generates this automaticity impulse. It goes to the AV node, right? And the AV node kind of hesitates for a second, and then boom, it lets it through. Well, an AV block or a heart block is just when that impulse right here at the AV node gets held up for just a little too long. That's all it is. That's all you need to know what a heart block is. Other than that, we just kind of need to know how to recognize them on an EKG, and then somewhat about the treatment of them. So a first degree heart block is when the conduction, right, hits this AV node and it's just a little bit delayed and it's constant. It stays at a constant delayed. So this is also, it's really not a true heart block because the impulse doesn't ever truly get stuck there permanently, right? Every impulse is hitting that and getting through. It's just slightly delayed. That's a first degree heart block. A second degree heart block is when not all the impulses reach the ventricles, and there's two types that we need to talk about, two types of second degree. So the first one is Mobitz 1. Those are the names of the categories. There's Mobitz 1 and there's Mobitz 2. Mobitz 1, also known as Winky Bach, is when the PR length progressively increases, and then there's a random block. So what I mean by that on this picture is that, okay, an impulse hits this, right? It's delayed for probably a second, or we'll just say not a second, but it's delayed for a second, then it goes through. The next impulse generates, it goes to the AV node, and let's say it's delayed 2 seconds, then it goes through. The next one is delayed 3 seconds, and then finally this fourth one, it just never goes through, and then the cycle restarts. So impulse goes, it's delayed a little bit. Second impulse, delayed a little bit longer. Third, delayed even longer. And then it just doesn't go through. So that's Winky Bach. Another way to think of that, and we'll talk about it in just a minute, is a quote is longer to longer drop, then you have a Winky Bach. Mobitz 2 is when this impulse is generated. Okay, it hits this. It's delayed at a specific interval each time, and then there's just a random drop maybe after the second or third impulse. So the SA node fires, goes to the AV node slow but gets through. AV node or SA node fires to the AV node slow, same slowness, gets through, and then finally just one of these impulses just don't go through. So that's Mobitz 2, and it'll make more sense when we go over the EKG in just a minute. And then the third degree is when you have total dissociation between the atria and the ventricles. So, SA node fires, this isn't even working, so the ventricle does have the ability to formulate automaticity, so it sees that there's not an impulse going through the AV node, so it may fire then, but then the atria is still firing, but the ventricle's not getting the impulses, so it may fire randomly. It'll make more sense when you get to EKG, so let's move on from here. But basically, in layman terms, that's what these heart blocks are. So what causes a heart block? Well, I will start with this point right here. A first degree heart block, which is the less severe, can actually be normal in athletes. And what I want to go over real quick is it's normal in athletes because they have well-trained and well-conditioned hearts, right? So what happens is the vagus nerve that innervates the heart and controls its heart rate, sees that this athlete's heart is well conditioned, it can well compensate with the body, and it doesn't have to beat as fast, right? So what it does is the vagus nerve increases its tone, which means it would slow the heart rate, right? Or it can delay this impulse, which can slow the heart rate. And that's where you get this first degree where the conduction's just slowed, and that's because these athletes have increased vagal tone, and it can be normal, and that is normal for normal athletes because their hearts are well conditioned. Other causes can be medications, kind of like a beta blocker, because beta blockers beta blockers act on the AV node, right? They block AV node impulses. And then coronary artery disease, like post-MI fibrosis, if you have an MI that affects the AV node, somewhat, then you can have these heart blocks. So medications, coronary artery disease, post-MI fibrosis, and then those first-degree heart blocks can be normal. This isn't super high yield for this topic, though. Okay, so we know that these heart blocks can slow our heart rate down, correct? So if we are symptomatic, it would be what? Bradycardic symptoms like fatigue, tired, lightheaded, pre-syncope, syncope, stuff like this. Again, not super high yield. You kind of need to have that in the back of your head. This is where all your bread, meat, potatoes, whatever about heart blocks is, where you need to know. You need to know this. You're going to see one question on your boards about a heart block, and it'll probably have something to do with reading and interpreting the EKG. So let's go. First degree, like we said, conduction is just slowed. Everything goes through, but it's just slowed. So what we have is a prolonged PR interval. So this is our PR interval. This is normal sinus rhythm, by the way. So P represents the atrial contraction. The Q, the R represents the ventricular contraction, right? QRS. So it would make sense that if we have a block between the atria and the ventricles, which is the AV node, that this would be lengthened. So let me look over here. Here's a first degree heart block. You see, look how wide these are compared to these. Well, that's because our normal PR interval should be under 0.2 seconds, right? So if it's over 0.2 seconds or over five little boxes being this bold square right here, then you have a prolonged PR length. You can see that this PR interval is well over that little 5 boxes, right? So you have a first degree heart block. Your second degree heart block, Mobitz 1, remember, that's Winky Bach, also known as. And by the way, the boards will say Mobitz 1. It will not say Winky Bach. So you have to memorize this. Mobitz 1 is Winky Bach. Mobitz 1 is Winky Bach. And remember, longer drop, then you have a Winky Bach. So Mobitz 1 is lengthening of the PR interval with eventual drop of the QRS. So we see right here a second degree. So this is, okay, this might look a little normal. It might be just a hair off. But look, this next one's even longer. Oh gosh, this next one's even longer. And then boom, all of a sudden, one of these impulses don't go through the AV node. And then it's kind of like a repeating cycle from there. But see, right here, this is a Winky Bach, a Mobitz 1. Longer, and then drop. Then you have a Winky Bach or Mobitz 1. Pretty simple, right? So then Mobitz type 2 is similar, but you have a steady prolonged PR and then a drop. A steady drop, right, is Mobitz 2. Or a steady, then drop, then you have a Mobitz 2. Right here, this is normal, or it's a little bit prolonged, but this is the same, right? It's consistent, and then you just have this random drop. So consistent, drop. Then you have a Mobitz 2. Let's go with third degree. So third degree is just when you have total dissociation between the atria and the ventricles. Some atria impulses get through, but it's just random. As we can see here, don't even know what that is. That's a QRS, but where's the P wave, right? So let me say this also. Your ventricle has the ability to generate a heartbeat if it notices the SA node's not doing its job, right? So when you have a third degree, you can have the ventricle starting the heartbeat, which would be the QRS first, correct? So, this might be let's just say that's a P wave. Well, there's no QRS, right? But then the ventricle's like, oh goodness, we don't have a heartbeat. Generate a heartbeat. There's the QRS. Here's another P wave. Where's the QRS? It's not there. Okay, the ventricle forgets to make the heartbeat. Here's another P wave. Total dissociation. If the Q's, which the QRS, and P's, which is the atrial contraction, if the Q's and P's don't agree, then you have a third degree. It's just total chaos. If it looks like total chaos, it's probably a third degree heart block. Okay, so How do you treat these? By the way, this is your bread and butter. You need to know these words, and you also need to know these images for the boards. That will be 100% the test question that's on your boards about heart blocks. It would be either the EKG description or the EKG, actually you interpreting the EKG. So treatment, if you have a first degree heart block, right, most are asymptomatic because it can be normal, correct? But if you did have any problems, it would be because of bradycardia. What do you give for somebody, first line for bradycardia, who's symptomatic? Atropine. So you just give them atropine. But more than likely, these people first degree don't need any treatment, just observation. Second degree Mobitz 1, which is Wiki block, right? Well, are they symptomatic? You know, if they're bradycardic, are they symptomatic or are they not? If they're not, you just need to observe them, correct? And if they are symptomatic, just give them atropine. If they're second degree Mobitz 2, that's a little bit more severe than Mobitz type 1. They probably need atropine or pacing, whether it's temporary pacing in the ED or, you know, a pacemaker. And then for third degree, at this point, these people, you know, they need, you know, their SA node, AV node, everything's messed up in their conduction system, and they need something to generate a steady, correct impulse. And so I think when the boards ask you, or if they ask you a treatment for third degree, the answer would be pacemaker is definitive, because, you know, you have total dissociation. You need something to pace your heart. And then if these patients, I would say second degree or third degree, if they present to the emergency department, obviously they're going to be bradycardic, and they'll probably be very symptomatic. And, you know, some of them might have a low blood pressure. So you want to get a control of that pacing. You want to get control of that heart rate. So you usually do that by, especially if atropine and other stuff don't work, then you can do transcutaneous pacing, I feel like is more common than transvenous. I'm not 100% sure. This is what I saw in the ED. But you can just some sort of pacing to get control of their vitals. Okay, so let's do a high yield vignette question. And again, heart blocks in general, I wouldn't say are very high yield on the boards, but I would know these EKG readings about the heart blocks, and then how to interpret these EKGs for them. So with that being said, let's do a high yield vignette question. A 16-year-old well-conditioned athlete presents to the ER with a contusion to the rib cage and associated chest pain. An initial EKG reads a PR length of 0.24 seconds. So right there, this sentence right here, this kid has an increased PR length, which is indicative of what? A first degree heart block, right? Okay. What is the diagnosis of the EKG, and what best describes the reasoning for it in this specific patient? So it's not giving us a strip, right? It's telling us the interpretation. And it's saying that this EKG shows an increased PR length of 0.24 seconds. What's our normal PR length supposed to be? It's supposed to be under 0.2 seconds. This one is a little higher. So you have a first degree heart block. That's your diagnosis. Well, what best describes the reasoning for the first degree heart block in this specific patient? Okay, so this is kind of a tour, right? You get the diagnosis, and then they want the reasoning why. So the answer choice would be, you have a first degree heart block and then an explanation for why it's a first degree heart block in this specific patient. Well, let's look at the specific patient. It's a 16-year-old well-conditioned athlete. What did we say was a common cause of a first degree heart block? Let's go back real quick. Common cause would be normal in athletes. Why? Because they have that increased vagal tone, right? So they can have this, and it can be normal, and it very well is asymptomatic. So your answer choices is, if you have an increased PR length, you're going to have a first degree heart block. And the reason that this kid had a first degree heart block was because he was an athlete. He was well conditioned. It says he's well conditioned. And so he has increased vagal tone. So guys, thank you for watching Heart Blocks. I hope this video made a little bit of sense. If you had to focus on a couple things on heart blocks, it would be EKG interpretation and EKG description. Those are your high yield stuff for heart blocks. But again, thank you guys for watching. Like the video if you've not subscribed already. Subscribed. Also follow the TikTok page. It's going good over there, and we will see you guys in the next video. Good luck with all your tests. You're going to do great.